Today we are going to talk about acute kidney injury and nursing management, so let's get started. We'll start with this question and then we'll discuss acute kidney injury. A 68-year-old male client with a history of hypertension and diabetes is admitted to the medical unit with complaints of decreased urine output, fatigue, and edema in his lower extremities. The nurse assesses the client and notes that he is hypertensive with a blood pressure of 160/100, tachycardic with a heart rate of 110 bpm, and has crackles auscultated bilaterally in his lungs. The client's laboratory results reveal an elevated serum creatinine level of 2.5, normal range, 0.6 to 1.2, and a blood urea nitrogen level of 40, normal range, 7 to 20. Based on these findings, the nurse suspects acute kidney injury, AKI. Which intervention is the priority for managing acute kidney injury in this client? A. Administering intravenous fluids rapidly to increase urine output. B. Administering furosemide Lasix to promote diuresis. C. Initiating continuous renal replacement therapy, CRRT. D. Encouraging the client to increase oral intake of fluids. E. Administering a dose of acetaminophen, Tylenol to alleviate discomfort. Answer: C. Initiating continuous renal replacement therapy, CRRT. Rationale: continuous renal replacement therapy, CRRT, is the priority intervention for managing acute kidney injury in this client. CRRT is indicated for clients with severe AKI, who are hemodynamically unstable or unable to tolerate traditional forms of hemodialysis. It helps to remove waste products and excess fluids gradually, preventing further damage to the kidneys. Options A, B, and D may exacerbate fluid overload and worsen the client's condition. Option E is contraindicated in clients with AKI, due to the risk of further kidney damage from acetaminophen's nephrotoxic effects. Acute kidney injury, AKI, represents a critical condition characterized by a sudden decline in renal function, resulting in the accumulation of waste products and electrolyte imbalances in the body. This multifaceted syndrome presents significant challenges in diagnosis, management, and prevention, particularly for nurses who play a pivotal role in the care of patients with AKI. Here we provide a comprehensive overview of AKI, including its pathophysiology, clinical presentation, diagnostic approach, management strategies, and the implications for nurses in delivering high-quality care to affected individuals. Pathophysiology of acute kidney injury, AKI, can arise from various etiologies, including prerenal, intrinsic renal, and postrenal factors, each contributing to impaired renal perfusion, renal parenchymal damage, or obstructive urinary flow. Prerenal AKI results from decreased renal blood flow, often secondary to hypovolemia, systemic hypotension, or reduced cardiac output. Intrinsic renal AKI involves direct damage to the renal parenchyma, such as ischemic injury, nephrotoxic insults, or inflammatory conditions like acute tubular necrosis, ATN. Postrenal AKI occurs due to urinary tract obstruction, hindering the normal flow of urine from the kidneys, and leading to increased intraluminal pressure and subsequent renal dysfunction. At the cellular level, AKI triggers a cascade of pathophysiological processes, including inflammation, oxidative stress, and apoptosis, culminating in renal injury and dysfunction. Ischemic insults or nephrotoxic agents disrupt tubular epithelial cell integrity, impairing tubular reabsorption and secretion functions. This disruption promotes the release of pro-inflammatory cytokines, chemokines, and reactive oxygen species, exacerbating tissue damage and initiating an inflammatory response. Additionally, the activation of apoptotic pathways contributes to tubular cell death and further compromises renal function. Clinical presentation and diagnosis. The clinical presentation of AKI varies depending on the underlying cause, severity, and duration of renal injury. Common manifestations include oliguria or anuria, fluid overload, electrolyte abnormalities, e.g., hyperkalemia, metabolic acidosis, and uremic symptoms such as nausea, vomiting, and altered mental status. Physical examination may reveal signs of volume overload, such as peripheral edema, pulmonary crackles, and hypertension, along with features of uremia, including asterixis and pericardial friction rub. In diagnosing AKI, nurses utilize a multifaceted approach encompassing clinical assessment, laboratory investigations, and imaging studies. Serial monitoring of serum creatinine and blood urea nitrogen (BUN) levels aids in assessing renal function and identifying trends suggestive of AKI. Urinalysis may reveal abnormalities such as proteinuria, hematuria, or CAS indicative of renal parenchymal injury. Imaging modalities like renal ultrasound or computed tomography (CT) scans can help identify structural abnormalities or obstructive lesions contributing to AKI. Additionally, nurses may perform hemodynamic assessments to evaluate renal perfusion and differentiate prerenal from intrinsic renal causes of AKI. Management strategies. The management of AKI focuses on addressing the underlying etiology, optimizing renal perfusion, and preventing further renal damage. Nurses play a central role in coordinating a multidisciplinary approach to AKI management, involving nephrologists, critical care specialists, pharmacists, and other healthcare professionals. Key management strategies include fluid resuscitation. In prerenal AKI, prompt fluid resuscitation aims to restore intravascular volume and improve renal perfusion. However, judicious fluid administration is essential to prevent fluid overload and exacerbate renal dysfunction, particularly in patients with underlying cardiac or pulmonary conditions. Hemodynamic optimization. Optimizing hemodynamic parameters such as blood pressure and cardiac output is crucial for maintaining renal perfusion in critically ill patients. Vasopressor agents may be utilized to augment mean arterial pressure and ensure adequate renal blood flow, while minimizing nephrotoxic exposures and avoiding hypotensive episodes. Electrolyte management. Close monitoring and correction of electrolyte imbalances are paramount in AKI management, especially hyperkalemia, metabolic acidosis, and hyperphosphatemia. Nurses collaborate with clinical pharmacists and dietitians to implement appropriate electrolyte replacement protocols and dietary modifications tailored to the patient's renal function. Nephrotoxin avoidance. Identifying and avoiding nephrotoxic agents, such as nonsteroidal anti-inflammatory drugs, NSAIDs, contrast agents, and certain antibiotics, is essential for preventing further renal injury in patients with AKI. Nurses play a crucial role in medication reconciliation, reviewing drug regimens, and adjusting dosages based on renal function to minimize nephrotoxic exposures. Renal replacement therapy, RRT. In severe cases of AKI, with refractory fluid overload, metabolic derangements, or uremic symptoms, initiation of renal replacement therapy, RRT, may be necessary to provide renal support and facilitate fluid and solute removal. Nurses collaborate with nephrology colleagues to determine the appropriate modality of RRT, e.g., intermittent hemodialysis, continuous renal replacement therapy, CRRT, based on the patient's clinical status, hemodynamic stability, and resource availability. Nutritional support. Providing adequate nutritional support is essential for optimizing outcomes in patients with AKI. Nurses collaborate with dietitians to formulate individualized nutrition plans, ensuring adequate protein intake while minimizing the risk of electrolyte imbalances and metabolic acidosis. Enteral nutrition is preferred when feasible, but parenteral nutrition may be indicated in patients with gastrointestinal intolerance or malnutrition. Implications for nursing practice. As key members of the healthcare team, nurses play a pivotal role in the prevention, early recognition, and management of AKI across various clinical settings. By leveraging their advanced clinical knowledge, diagnostic skills, and therapeutic interventions, nurses contribute to improved outcomes and enhanced quality of care for patients with AKI. Several implications for nurses in the management of AKI include clinical assessment and monitoring. Nurses perform comprehensive assessments and ongoing monitoring of patients at risk for AKI, identifying subtle changes in renal function and implementing timely interventions to prevent progression to AKI. Education and advocacy. Nurses educate patients, families, and healthcare providers about the risk factors, signs, and symptoms of AKI, promoting early recognition and proactive management strategies. They advocate for evidence-based practices such as nephrotoxin avoidance and hemodynamic optimization to minimize the risk of AKI development or progression. Interdisciplinary collaboration. Nurses collaborate closely with multidisciplinary teams, including nephrologists, intensivists, pharmacists, and allied health professionals, to optimize AKI management and facilitate seamless transitions of care across different healthcare settings. Research and quality improvement. Nurses engage in research and quality improvement initiatives aimed at enhancing the understanding, prevention, and management of AKI. They contribute to the development of clinical guidelines, protocols, and best practices to standardize care delivery and improve patient outcomes. Patient-centered care. Nurses prioritize patient-centered care, addressing the holistic needs of individuals with AKI, including physical, psychosocial needs.